Yes.
Okay.
પૈસાની દાઢી વધતી જાય છે.
Good evening.
ટાઈમ નથી મળતો. દીપેનભાઈ એના માર્ગે.
Good afternoon, sir. મજામાં? Sir, you are muted.
એ તો પ્રશાંત બધાને મ્યુટ કરી નાખે.
ગુડ આફ્ટરનૂન, કેમ છો?
ગુડ
All
આફ્ટરનૂન.
right, sir.
Yes, Agnik, we start.
Okay, sir. Okay. Good afternoon, one and all. This is Shagnik, the designated moderator from ClearNet for this session. ClearNet is very proud to be a part of this webinar as its digital partner. Now, before moving forward, I would like to play a short video of ClearNet about its intro. Thank you everyone for their kind patience. As we all know, ClearNet is India's largest live digital CME and doctor-generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clearnet.com, where you can watch lots of live sessions conducted by doctors with great expertise all across the world. We also have MedWiki service, which is a medical Wikipedia, which is exclusive for the doctors to read as well. We are very grateful to this association and this star-studded panel with such highly affiliated doctors to be associated with us. Now, before we start the session, I would like to go through a few things. I would like to kindly remind you that whenever a doctor or a faculty member is giving a presentation or has the virtual stage, I would like the other participants to keep themselves muted for smoother audio stream. Also, while any faculty member is taking up the virtual spotlight, I would like them to keep their video on as well. Now, without further ado, I would like to hand over this session to Dr. Prashant Karia, sir. Sir, if you may, please.
Thank you, Agnik. On behalf of NNF Gujarat, I, Dr. Prashant Karia, the Secretary of NNF Gujarat, welcome one and all to the 6th session of the 2023 Neonatal Pathshala. I request our President, Dr. Dipen Patel, to welcome one and all.
Thank you, Dr. Prashant Pai. Good afternoon, all colleagues. Today, on this 6th day of Pathshala, we are going to have expert talk by Dr. Jatin Mistry. He is going to discuss on hypothermia therapy for hypoxic ischemic encephalopathic infant. So, on this expert talk, he will brief an idea about how to take care of a baby who is moderate to severely asphyxiated. So, as a part of this learning activity, we welcome you all on this digital platform. I request Dr. Prashant Bhai to take over the session and brief the faculty.
Thank you. So today we will be having Dr. Urvi Sanghvi as a coordinator for the therapeutic hypothermia session. Urvi has done a DNB in neonatology and she is practicing in Rajkot. So I request Urvi to introduce today's expert, Dr. Jatin Mistry, and Dr. Somshekhar Nimbalkar, sir. He is our advisor. So I request Urvi to introduce both of them. Thank you.
Good afternoon all. Thank you, Dr. Prashant, and thank you, Gujarat NNF, for this opportunity. We have today's topic on therapeutic hypothermia, which is a very controversial and a very research-based topic, and Dr. Jatin Mistry will enlighten us on this. He is an MD pediatrician. He has done his MRCP-CH and CCST in neonatal medicine from UK. He worked as a consultant in UK as well as presently in India at Setu Newborn Care in Ahmedabad. His special interest is neonatal ventilation and neonatal neurology. The expert in this talk is our own Dr. Somshekhar sir, who I think don't need any introduction. He's an All India face. Sir is expert in research in hypothermia. He is professor and head of neonatology at Karamsad Medical College. I request our speaker to start the session.
Urvi madam, Dr. Somshekhar Nimbalkar is a global case.
Yes, global face. Correct.
International faculty.
Yes, sir. Yes, sir.
Okay.
So over to you, Jatin bhai. Yeah.
Yeah. Thank you, NNF Gujarat, for giving me this opportunity to present and talk about therapeutic hypothermia, which is a very interesting topic. I would just share my screen. Is it visible? I'm not sure. Is it?
Yes.
Okay. So yes, I would like to thank especially Dr. Prashant Bhai, Dr. Dipen sir, Dr. Urvi madam. When Prashant Bhai called me for this talk, that you have to deliver a talk on therapeutic hypothermia, the first question I asked him was who is going to be our audience. As you know, this topic is so diverse. There is so many. It has been going on in all our conferences for last decade actually. Still, it draws our attention because there has been a lot of ups and downs, and there has been controversy surrounding that. So it was very important to know the audience. And he said that there will be a diversity of audience as well. There will be some PGs, there will be some fellows, and there will be private practitioner, and there could be some seniors as well. So for next 1 hour, I would try to do justice with everyone and try to present, and let's discuss with that. So therapeutic hypothermia in neonates. Why this topic is so important? I think we need to understand that. If you see it, till date, for hypoxic ischemic encephalopathy, other than therapeutic hypothermia, there is no single effective evidence-based therapy other than conservative management. So in early 2000, we started having evidence about therapeutic hypothermia in the Western world, and then it started coming into the low middle income countries as well. But at least we can surely say that it is the most effective evidence-based therapy in high income countries, and to certain extents in the low middle income countries as well, like us. However, we started adopting protocols, we started practicing, we started producing our own evidences from India and from certain various reputed units in India. But then there is a Helix trial came in 2020 and early 21. And that created a lot of dilemma because it was clearly saying that it can lead to, it showed some diverse results actually. So actually, here in discussion, we need to really know what we need to understand is what are we going to do if we are going to face a baby who is going to have a severe hypoxic ischemic or moderate hypoxic ischemic encephalopathy. And this topic is also very important because we need to bear in mind that majority of litigations in neonatology is around perinatal management. Sorry. Around perinatal management, and it applies to obstetrics as well, and it applies to neonatal as well. So with this all, I think fairly this is a very important topic, and we need to discuss that. So I was asked a question by a pediatrician. I will just share that because I did not have answer to that. There was a baby born by emergency CS required full neonatal resuscitation. His Apgars were 1 minute 3, 5 minute 4, and 10 minute for 5. This was in peripheral part of Gujarat where there was no nearby level 3 NICU, as per as knew. Pediatrician is calling and asking for advice what he should be doing. And you advise that this baby should be transferred to the tertiary unit because this baby does need cooling therapy because he meets the criteria. Now the next answer is that relatives are really reluctant to come. He is asking what he should be doing. Should he cool this baby at his place or not? And you know that is basic NICU with a ventilator, but you know that there is no in-house blood gas machine, there is no echocardiograph, no portable X-ray, no CFM, and the cooling device is one of the basic one, not a servo control one. Okay, so the question comes: would you advise him to continue cooling at his place with his whatever resources he has, or would you say that don't cool and continue with the conservative management? Now, a few years back, if you would have asked, then probably we would have said that, okay, whatever the cooling device he has, that he can continue. But now you need to consider that since Helix trials showed that there is an increased mortality in a unit which is no monitoring, should we advise to continue or not? That controversy came in. And really, I did not have really answer. And I did advise him that you really need to convince them he should be in a tertiary place. and I'm sure all of us who are working in tertiary center, they are getting exposed to certain kind of referrals, and even our pediatric colleagues are trying really hard, but they do end up that relatives are reluctant or they are refusing, and there are so many other reasons, and we don't have the answer to that. So I'm leaving this question here only. We will discuss about cooling and see whether at the end we can discuss about this more or not if the time is available. So today's talk, the outline, I'm going to talk about the definition of HIE and diagnosis. What is the evidence has been for the cooling? We will touch on how to do cooling, monitoring, what are the side effects, what are the equipments available in market, and how are they being used? What is the role of cerebral function monitor, which is amplitude EEG, and ultrasonography in prognostication? We will talk about Helix trial, and at the last, we will talk about what has been NNF saying about that. That is NNF positional statement on cooling therapy. So let's say HI is one of the commonest cause of neonatal encephalopathy, as we all know that. Most common cause of death and serious brain injury in term infants, affecting at least 1.2 million infants globally every year. And the most important part is that over 96% they occur in the LMIC. So we can say that majority has been the burden has been on the lower middle income country of the hypoxic ischemic encephalopathy. And we know that all the trials which has been done before, they were in HICs, where the evidence has come from. So majority of burden is on us. Now, data from the HIC suggested that there's a clear benefit on death and disability is reduced at 18 months. Even to the extent that the ILCOR guidelines in 2015 recommended that therapeutic hypothermia should be a standard of care in the resuscitation itself. So we can see the impact of this intervention. This was one of the major strides in neonatology. This has a very strong evidence base, and we are in the country which we are facing a majority of the burden of it. So that is why it is very important. Start with definition. Actually, we all know that in medical school, we have been taught hypoxia means a partial or complete lack of oxygen in the brain or blood. So that is hypoxia or anoxia. Asphyxia is something which in state in which placental or pulmonary gas exchange is compromised and ceases altogether, particularly in the context of HIE, that this is a state where there is a lack of gas exchange. And what is ischemia? Ischemia is a reduction and cessation of the blood flow to an organ, which will compromise both oxygen and substrate delivery to the tissue. So there is a lack of blood flow to the organs. That is ischemia. And what is HIE? So if you get a hypoxia and ischemia, and if it leads to abnormal neurological behavior in the neonatal period as a result of HIE, a hypoxic ischemic event, that is a hypoxic ischemic encephalopathy. This is as simple as that. So we have a group of babies who are having these features, who have hypoxic events, who go through asphyxial events, who have hypoperfusion, and they eventually end up in having neurological pattern. How do we confirm that? So we have been learning this chart from medical school, that is a modified Stannard and Stannard classification, which divides a level of neurological abnormality in stages, stage 1, stage 2, and stage 3. You have to examine baby's level of consciousness, neuromuscular control. There are neonatal reflexes, and then baby's autonomic reflexes, seizures, electroencephalocal EEG findings. And this all together, you divide that this baby is moderately encephalopathic, severely encephalopathic, or mild encephalopathic. And it helps in the prognostication as well. So you had a baby who had a hypoxic ischemia. You had abnormal behavior. So you can label this baby as a hypoxic ischemic encephalopathy. Add to that, Western world added that you can confirm that by an additional finding, which is EEG, but every center can't have an EEG. So there is something called cerebral function monitoring, which is amplitude integrated EEG. It is a method of continuous tracing of EEG that has been also used in many Western setups where it is basically amplified filter and compressed trace basically of the EEG, and it is presented in a semi-logarithmic transformation. So that has been also used, and that can help us in classification. We will talk about EEG later on in this session. So, okay, let's go in depth of it. What is pathophysiology of HIE? So starting from left, if you have a baby who end up in having a hypoxic ischemic injury, okay, let's say there has been acute insult. What will happen? Within minutes, there is a lack of blood flow, lack of oxygen and glucose delivery, anaerobic metabolism, high lactate, and eventually it will lead to cell death in minutes. Now, this is the stage. There is a primary energy failure, which will result in cell death. Here is you are trying to resuscitate the baby. Okay, so there is much not you can do at this point. But you have, let's say you have resuscitated in this phase and baby is ending up in going into what we know as a reperfusion. So here the brain will get reperfused. Okay, so the reperfusion starts. And this process is usually, this is the latent phase. This lasts for up to 1 to 6 hours. Okay. Once the reperfusion occurs, there is a cascade of events which will lead to inflammatory process. There is a cytotoxic edema. There is a free radical injury, which will eventually be responsible for something known as a secondary energy failure. And that will lead to the cell death. So really, if we look at, you have a HI, you have energy depletion, you have a primary neuronal death, and then there is a reperfusion, which can lead to the secondary neuronal death. So this period is the window, therapeutic window, that if you have an intervention which can be applied, which can lead to, which can reduce the secondary neuronal damage, okay, which occurs by number of mechanisms, which we won't discuss. So any neuroprotective mechanism or any neuroprotective intervention has to begin within first 6 hours of life. That is the base of whole this therapeutic hypothermia. So there was a hypothesis, or there was proven in animal models, that if you have a therapeutic window during which you can reduce the body temperature to 33 to 34 degree in first 6 hours, and if you can last this for 72 hours, and then you can progressively and cause cautious rewarming, then it can definitely reduce the secondary neuronal damage, which will eventually lead to reduction in mortality as well as in neurodisability. And on that basis, there were a number of trials actually happened, and the evidence started coming up in the Western world. So just to summarize those evidences, I mean, it's a very congested, but if we can read through, in 2005 NICHD, and 2009 TOBI, these are the 3 landmark trials of cooling, which is happened in the UK and USA and European countries. What they showed that if cooling can be commenced within first 6 hours, and if you bring the target temperature to 33 to 34 degree for 72 hours, all this showed consistent result that there is a reduction in the death and mortality as a primary outcome. Further to this, there were some more larger trials, Neo and Euro trial, then China study came, I study came. So by 2011-12, we had a number of major trials which showed that it became a standard of care in Western world actually. Majority of the units have started adopting cooling as a mode of therapy, and in fact during that time I was my registrarship was in UK, and I'd been part of TOBI trial as well, where babies were recruited actually. So I had seen a lot of babies where, and it became most of the centers in UK, there was a standard of care that baby will come, there was a HI, meets the criteria, you will have to cool that baby. Okay, so that eventually led to there was a Cochrane review came in 2012-13, and they examined this, that there are a number of trials leads to a systemic review, and they clearly showed that there were a huge number of babies, like nearly 600 in each arm, and all of the study they showed that it benefits the hypothermia group. Here, the primary outcome was death and disability at 24 months, 18 to 24 months. And in all that, all the studies did prove that it is a clear-cut advantage to the cooling group. So they showed that there was a risk reduction by 25%. Number needed to treat was 7. And there was an increased survival at 18 months with normal neurological outcome. So clearly, it showed that there is a huge improvement. Even they did a subgroup analysis that in moderate HI, how does it behave? And severe HI, how does it behave? So clearly showed moderate also got benefited, and the severe HI group also got benefited. So there was no question, and it was adopted by every unit that. So meanwhile, what happened in India? We discussed that, can we extrapolate these results in Indian setting? Then can we adopt the therapeutic hypothermia as a mode of standard treatment for all the babies who are having features of HI? And in fact, before that, even I get that there are some of the units in India also, doing therapeutic hypothermia by the low-cost devices already. Okay, so to extrapolate these results and adopt practices, we needed to make sure that these are safe, effective, and the intervention is feasible as well. And if you look at this Indian studies prior to Helix trial, there are 6 or 7 studies between 2012 to 2020. And they were all in a very well-known setups like Vellore, Calicut, Manipal, St. Joe's, Mangalore, and this all used cooling device which was used was a cool gel or phase-changing material, and these all showed that there was a improvement in the neurodevelopmental outcome at 18 months, and they showed that there is a reduction in mortality as well. So even this guys also conducted a systemic review, actually, therapeutic hypothermia for HIE using low technology device, because there was a concern that Western world was using servo control device, and we had been using that with the gel pads. So this review also showed that there is a improvement, and it was favoring the therapeutic hypothermia. There was another RCT, systemic review of RCTs from low and middle and countries prior to Helix trial, and there were this. You can see the number of trials between starting from 2003 to 2020, and this all showed that eventually the outcome was better for the therapeutic hypothermia group. Okay, so you can see that, and there was a fairly good number, 670 babies in the cooling group and 641 in the control arm. So this led to discussion that, okay, so I'll stop here and we'll discuss about whom to cool, how to cool, when to cool. Okay, so which are the babies candidates for therapeutic hypothermia? So the babies, all the trials used that neonates were more than 36 weeks of gestation. All the neonates were more than 1.8 kg. And then there is the ability to start treatment within 6 hours of birth, so that this is the latent phase where you start. And there should be evidence for hypoxia, ischemia, and encephalopathy. So you should be aware of that. There is you meet this criteria before you consider them for therapeutic hypothermia. And then on top of that, okay, you have this, then how do you justify this baby as a hypoxia, ischemia or not? So this is something known as the criteria A and B. In criteria A, you look for hypoxia and ischemia evidence, means that if your cord blood gas or cord first blood gas within first hour of life, your pH is below 7 or base excess is more than 16, Apgar score of less than 5 at 10 minutes, or resuscitation efforts, continued need for PPV and intubation at 10 minutes. So in this criteria, actually, I remember for Toby trial, there was only one of them is required to prove that this baby has a ischemic insult or hypoxic insult at the time of birth. And if you meet one of the criteria, you look for criteria B, which is a neurological criteria. So in neurological criteria, different studies use different way of doing it. For these two popular trials, if you look at NICHD, they use modified, they use 6 scoring system kind of thing. 6 symptoms: level of consciousness, activity, muscle tone, posture, reflexes, and autonomic function. And they said in moderate group and severe group, if you have more than 3, then you will classify them. It is a neurological criteria has been met, and this baby can go for the cooling. While in Toby, it was very simple. If the baby's consciousness is affected and you have one of the anything abnormal like muscle tone or reflexes or seizure, then you can consider them for the cooling. So that is a abnormal neurological examination. Anything in the tone, consciousness, reflexes, and seizure in first 6 hours, if you find any of this, then this baby can meet for the cooling criteria. In Toby, they have added a criteria actually optional, which is a cerebral function monitor or amplitude integrated EEG. So how to do cooling? If you decide that if you have criteria A, criteria B, and then you decide to cool, then you need to know what is the procedure of cooling, what are the equipments being used, and what is the monitoring. So first we need to understand that there are phases of therapeutic hypothermia. If you decide that within 1 hour that this baby needs cooling, okay, your baby's temperature is 37. You have a cooling in 3 phases. First is the induction phase, second is a maintenance, and third is the rewarming phase. Okay. So in the induction phase, you try to bring down temperature to the target temperature, which is 33 to 34 degree. Okay, and this is fairly you should be able to achieve in that 45 minutes to 1 hour time. And most of the study demonstrated that you will be they achieved this within the 1 hour of life. Then you try to maintain the stable temperature control for another 72 hours. Okay, so your body, the central core temperature, rectal temperature, can be monitored for 72 hours to 33 to 34 degree. That will complete your maintenance phase. Okay, once you complete 72 hours, then you start rewarming. That will be very gradual. You will increase the temperature by 0.5 degree per hour, and you will try to achieve that over next 12 hours, and when you reach to normal body temperature. So it was very scientifically decided phases of therapeutic hypothermia: induction phase, maintenance phase, and there was a rewarming phase. So this is induction phase, maintenance, and rewarming. Okay. So where should be cooling? Now, most of the standard guidelines did recommend that it has to undergo in a level through NICU. This is all the babies who are very pretty sick babies. They need to have a good ventilation facility. The units should be having a facility for central venous and arterial access. The unit should be able to provide inotropic support, adequate nursing care. They should be having a continuous monitoring of vitals, and there should be a follow-up for long-term neurodevelopmental outcome. These are the prerequisites. I would say these were all mandatory requirements. The desirable was amplitude EEG and MRI facility, where you can do this thing. If it is desirable, then you can cool these babies. So number of cooling devices has been used in various setups actually. I'll just show some pictures. These two first, Criticool and Tacotherm Neo. These are the servo control devices. These are the devices which has been most popularly used. Very expensive ones, but they provide a very fine control. Once you set it, the temperature throughout remains up to the desired target range. So this has been the most popular. Even Tacotherm Neo had a previous version which had this Neo had a simple tacotherm, which was not servo control mode. That has been also used in many studies. Cool cap, nobody does that now, but it was used in the selective head cooling, and there are cool packs has been used in ice study and some other studies that in Indian setups, this kind of ice packs has been used as well. The low cost devices, I think there has been a lot of low cost devices because as I mentioned earlier, that all the Indian studies has been done in the setup with the phase changing material, or they had a ice packs, or there was some cold water filled with the gloves. And sometimes some of the studies used as a fans as well. So these are the low cost devices which were used in the intervention. So this is just a picture. You can see this baby wired up with a lot of things. Baby is ventilated. You can see that the EEG leads have been applied to brain and head, and then it is being monitored. This is a servo control device. The temperature is 33.4. This is a cooling mattress which has been wrapped around the baby. I'm sure the baby has umbilical lines as well. So I guess this baby is a pretty sick baby who is undergoing therapeutic hypothermia. And we can see that how much intense monitoring is required. There is a cardiac leads. So just to get a hint of that, really, this is a very intense monitoring is required in all these babies. This is just a picture of simple tacotherm device you can see underneath, and this is cerebral function monitor. Phase changing material, it is very popular in our country. Actually, it is popularly known as Meracredal. It has been used in many studies. It also provides a good control, fine control. What has been the concern with low cost devices that actually when they have a rapid fluctuation in temperature, for example, if you have been using ice packs, your temperature can drop drastically. And there has been quite labile temperature. So in that cases, you will need a really more nursing input. If you are not able to provide a good constant nursing supervision, there is no point. Otherwise, you will end up in having a hypothermia injury. There is increased incidence of shivering. There is high incidence of fluctuation, and precise control is very less likely with these devices. So we need to be really mindful. If you are not using servo control devices, your nursing input is much increased. So does this cooling cause any adverse effect? And as we know that in medicine, there is no intervention doesn't come without side effects. So this is one of the therapy, why it has been recommended in level 3, because it needs intense monitoring. Okay. So if you see respiratory, sometimes cooling babies do have an increase in oxygen and it can aggravate your underlying pulmonary hypertension. Even it is a fact that sometimes pulmonary hypertension, if your baby is pretty sick, sometimes you may not cool and take your clinical judgment actually. Cardiovascular, all the cooling babies will get sinus bradycardia. It is allowed to a certain extent. Blood pressure irregularities, they can get arrhythmias as well. It is very well known clotting abnormalities. They have a deranged profile. They can have a abnormal clotting. Skin fat necrosis, which is something been seen quite frequently. I wouldn't say I have not seen many, but it has been reported that subcutaneous fat necrosis has been known and reported complication of cooling therapy. Even it can affect the drug metabolism. I mean, if you've been giving, let's say, phenobarbital, or it takes a longer time to disappear from the body. It takes a long time. The baby remains drowsy even after days after stopping cooling therapy, because it slows down your metabolic process. And it can also end up with the electrolyte imbalance. It can lead to acidosis. It can lead to hypoglycemia. So this is just to highlight that you need a really good care, good monitoring of all the systems. Good even skin care is required. You need to daily look for there is any developing fat necrosis patches or there. You need to look at continuous. You need to have chartings properly. You need to monitor the renal parameters as well. So it is one of the most important therapy which needs a lot of monitoring. Okay. So as I earlier mentioned, when you are cooling a baby, you need to have there's something amplitude EEG may benefit the baby, which is though it is not mandatory. But I think we will just talk about it. So as I said, it is a very amplified. It is basically a continuous EEG, which is amplified, filtered, and then it is being compressed as a semi-logarithmic transformation, and it gives you actually a trace. Actually, if you have seen that. So just picture. There are two classifications. There is one voltage classification. There is another pattern classification. Okay. For understanding, we can just go through the voltage classification. If you see this trace on the left side, there are voltage numbers 0, 5, 10, 25, and 50. Okay. And if you see this blue color band, there is an upper margin and there is a lower margin. Okay. So what is ideal? Let's say on normal, there is upper margin should be above 5. Okay. Lower margin, and the upper margin should be above 10 microvolt. In this case, it is that. So this is a normal trace, and this is something, a big band overcomes here. This is sleep wave cycling, which is a normal phenomenon. Okay. If your baby who is moderately encephalopathy, then what are you likely to get is that your upper margin will be more than 10, which is seen in this picture. Okay. And your lower margin is below 5. So your 5, this line, if you look at this, is touching almost 5 and going below 5. So you will get a very broad band if you have moderately abnormal CFM. Okay. Same way, if you have a severe abnormality, then what are you likely to get is that your upper margin will be less than 10 and lower margin will be less than 5. Okay. So like in this picture, you can say. And there are some other ways or other patterns you will see, which is like a burst suppression, flat trace, which comes with the experience only. But for understanding purpose, whether it is a moderate or severe, we need to understand this concept of trace being in what voltage range. So let's say this baby, this is number 5 and this is number 50. So obviously you are above 5, above 10. So probably this is a normal trace. Okay. But if you look at this picture, this is a moderate, because your lower margin, it's touching 0, but upper margin is about 20. So this is a very broad band. This is seen in the moderate encephalopathy. Okay. And this is you can see that there are some spikes, but if you average it out, the upper margin is around below 10 and lower margin is below 5. Okay. So this is very simple, very handy tool, bedside tool. It can quickly tell you which is abnormal or normal, and it has got a good prognostic value. Okay. So that will help. What is this? This is another pattern actually. This is a more of, I would say it is a severe only, but there are some burst suppression. You can see that the baseline trace is suppressed, okay, but there are a lot of bursts are there. So this is known as a burst suppression pattern. Okay, it will classify into moderate or severe encephalopathy. And this is completely flat trace, where you see that the upper and lower margin both are touching around 0 or less than 5, and sometimes you will see some electrical activity. This baby has a very poor prognosis neurologically. Okay, apart from deciding on encephalopathy, it does help in classifying, picking up neurological seizure, electrical seizures as well. So you can see that this is a CFM trace, 0, 5. Your trace is running around 5 or something, but you get a lot of intermittent spikes where you get a electrical activity more than 25 or 50 up to sometimes. So this kind of clusters of spikes, you can call it as a seizure. Those who have used, you will say that there is a EEG, means if you put a cursor on one line here, suppose this green line is over here, then it will expand what is the electrical activity at that point. And this is a spike wave activity, which can say that this is ongoing seizure actually. And this may be looking at this CFM, this is like a status epilepticus. It is a continuous abnormal EEG. Okay, so it does help in sometimes you may not get even encephalopathy. It's just multiple seizures happens, and you can identify. Even I've seen babies, sometimes you don't have a clinical seizure, but there are a lot of electrical seizures. And if you have a certain number of electrical seizures, then you might would like to treat rather than leave it like that. So this is a long back. I had a trace of a baby who came with the severe encephalopathy. We cooled that, and there were a lot of electrical seizures. And within 36-48 hours, we got a lot of improvement, and we got moderate first, and then we got normal. So I'm trying to run it video for about half a minute or so. Let's see if it goes well. So you can see that the baseline is below 5, okay? And there are some spikes. So these are electrical seizures, multiple electrical seizures. See that, okay? As the video is going, you can see that the lower band is getting thicker. Okay, so this was below 5, this above, still it is quite severe, and you can get seizures as well. But I think your spikes, big spikes are getting lesser, okay? So now you go ahead. Okay. So look at here, still it is severe, upper margin below 10, lower margin below 5. So this band is getting thicker and thicker. This is only 24 hours recording, 36 hours, I guess. Okay, we can see that the upper margin is getting up to 10 now. Lower margin is also reaching up to 5. So this band, if you compare with what you first saw, that was severely abnormal. And this band is getting thicker. Okay, now you see it is above 10 and it is above 5. So those babies who get this kind of pattern, they have a really good prognosis. This is a very good prognostic marker. Okay. So that is how it is helpful. Okay, so amplitude EEG is a prognostication. Normal background at 18 to 24 hours is associated with a good outcome. See, if you see, like this baby presented with severe encephalopathy, but we could see in 36 hours, this baby started getting normal CFM. So development of the sleep wave cycle before 36 hours is associated with a very good outcome. However, if you have persistent background abnormality is associated with increased risk of death. So if you can say that after 72 hours, the trace is same. You can counsel the parents that this is not good. This was a study from Professor DeVries, who has been doing a lot of work in amplitude EEG, and they clearly mentioned that CFM background changes at 24 hours of cooling is associated with better outcome. There was another systemic review actually on amplitude EEG, that it is a prognosticating tool. Yeah. So they said that following 72 hours are a helpful guide when considering counseling of parents about the foreseeable long-term neurological outcome. So you can counsel the parents on basis of your CFM finding. Doppler, another bad side prognostication tool. Okay, so in HI we know that there is a loss of autoregulation. Okay, so it is very important by 24 hours if you have a resistance index below 0.55, it is a predictive of poor outcome. Okay, and it has been well proven. So you put your cursor on anterior cerebral artery and take a Doppler and you count resistance index, and if it is below 0.5, then indirectly it indicates that you have not been able to achieve the autoregulation, and this baby is likely to end up with abnormal neurological examination. Over the years, there has been a considerable research on MRI and MR spectrometry. Okay, there is a strong evidence MRI and MRS are reliable predictors of neurological outcome. The ideal time you would like to get MRI is around second week or maybe 5 to 15 days of age. In acute injury, there will be injury in basal ganglia and plex, means posterior limb of internal capsule. White matter and cortical changes are suggestive of more chronic and repetitive injury. Okay, and if you are doing MR spectrometry, you need to get the lactate by N-acetyl aspartate ratio in basal ganglia. That is also quite predictive of long-term outcome. So it has been increasingly used. I think in most of the trials now they had used MRI findings as a confirmatory. Particularly when you are not sure about diagnosis or you want to guide the parents with prognosis, you can definitely use MRI findings even earlier than 5 days as well. So then comes the ELIX trial. Okay, this paper came before even ELIX trial got published. Actually, rise and fall of therapeutic hypothermia in low resource setting, and it was very circulated in most of the medical groups and things like that. It was a well-designed RCT actually, conducted over 7 sites in Southeast Asia, 5 India, 1 Sri Lanka, and 1 Bangladesh. It ran from August 2015 to February 2019. They used servo-controlled devices. An evaluation of HI was done by 3 SLA MRI biomarkers. So spectrometry was also used in the diagnosis as well. This was in low-middle income country. So what they looked for, the primary outcome was that they looked for death for a moderate severe disability. And in secondary outcome, they looked at the death from any other cause at 18 months, severe disability among those who survived, microcephaly assessed at the 18 to 22 months. Okay. So this was the ELIX trial. They recruited about 200 babies in each arm. The results were quite surprising actually. All the Indian prior studies did show that there is improvement, but this study showed that there was no difference between RCT arms for primary outcome. So between therapeutic hypothermia and normothermia, there was no difference in outcome of death and moderate or severe disability. Contrarily, they found that mortality at 18 months was higher in therapeutic hypothermia group. So this was shocking that therapeutic hypothermia is harmful, and it can cause harm. And also they looked at a lot of short-term outcomes. And in the short-term outcomes, they found that 7 were worse in therapeutic hypothermia. So actually no improvement, no primary benefit. Secondary outcome was poorer. Even mortality at 18 months was poorer. So eventually it led to a lot of dilemma. This was the forest plot. This is the 7 center they used in Dhaka, Bangalore, Chennai, Sri Lanka, Mumbai, and Trivandrum. And pretty much all centers showed that it was the usual care which was being favored rather than cooling group. And if you see that there are 202 babies in this arm and 206 babies in this arm. So fairly good number of neonates were included in these studies. So what next? This caused a lot of debates and discussions. And I think after that, NNF came up with the position statement in October 2021 that guidelines for use of therapeutic hypothermia for treating neonates with HIV. So what NNF did is that, from reading the statement actually, they included 24 RCTs. They conducted a review actually. And out of the 24, 7 were in high income group and 17 from the lower middle income countries. They extracted information on inclusion criteria, exclusion criteria, what was the method of hypothermia, what was the target temperature, what was the illness severity of underlying illness. And their main outcome they looked at death till discharge, death or severe neurodisability 18 to 24 months. And they found that actually therapeutic hypothermia is likely to decrease. I forgot to mention, in this include even helix was included in this 24 trials as well. Therapeutic hypothermia is likely to decrease death or severe disability and cerebral palsy at 18 to 24 months. This was a statement outcome of this 24 studies. that even in both HIC and LMIC as well. And there is significant heterogeneity. They also noted that in LMIC, all the studies have significant heterogeneity and lack of certainty of diagnosis of asphyxial encephalopathy. So they further went on to add, mortality before discharge for infants moderate to severe HIE who had a quad pH below 7 showed no significant heterogeneity in studies from both groups. Okay, so if you are in both groups and quad pH was below 7, and they showed that there was significant benefit in favor of therapeutic hypothermia in both the subsets. So NNF went on to recommend, and they recommended that if you are ending up with having a baby who is more than 36 weeks, who has a less than 6 hours of life, and admission temperature is 36 to 37.4, and you meet one of these all these criteria, your pH should be below 7 or base excess minus 16 more than on quad plus or first gas within first hour, and your UPGAR should be below 5 at 10 minutes or at least 10 minutes of positive pressure ventilation, and there should be history of acute perinatal event such as but not limited to placenta, but means placental abruption, you have a rupture or cord prolapse, any acute event. And upon top of that, you need evidence for encephalopathy as well, which can be evident by your neurological examination. Okay. So NNF made it very stringent but very strict guidelines that who can be offered therapeutic hypothermia. So you need to have all of this. If you look at TOBI criteria or anything, you need one of this to provide that you have evidence of hypoxic ischemia. But here there is an and top of that you need neurological evidence as well. They also mentioned who should not be offered therapeutic hypothermia. Those who are moribund, obviously, major congenital or genetic abnormalities, neonate with severe intrauterine growth restriction or severe coagulopathy, and evidence of severe head trauma or intracranial hemorrhage. Well, you can defer cooling in this kind of babies. They did recommend that it is a servo control devices should be preferred cooling device. However, if non-servo control device such as gel packs or PCM devices are used, then it will be necessary to have 1:1 nurse to patient ratio to monitor the maintenance of temperature and take immediate corrective steps to keep the temperature within the target range. So yeah, you can use normal device, not servo control, but you need to have a good monitoring patient to patient, but servo control devices are preferred. So I think with this, we will conclude. I think try to cover the aspects of cooling therapy. I think I'm not sure the time is also okay. So we would like to, I would just at the end of this, we would like to see where are we now and what we can do. So I think I conclude that therapeutic hypothermia is the single most effective therapy for HI. Okay, you have a baby with hypoxic ischemic encephalopathy, therapeutic hypothermia is definitely, and it is well proven in the HIC. It is also proven in LMIC to a certain extent, but there is a considerable debate is going on. Okay, it should be practiced only in tertiary center. That is my view, and I think we need a good. These are pretty sick babies who need a lot of monitoring. At least we don't do any harm to this baby, so it should be restricted to tertiary centers only. Servo control devices are preferred definitely because you get a stable control. You don't induce any trauma due to hypothermia too much of. And I think if there is a national cooling registry, if we can maintain where we can log in and give details, then we will have a better database. We can benchmark and we can come up with a good data that would be way ahead to answer many questions actually. I think with this slide, I will end my talk. Thank you very much.
Thank you, Dr. Jatin. Thank you for sharing your opinion. And if you can stop sharing, and I wanted to make a few comments before we start asking questions.
Yes, sir.
I think in 2021, this trial was published, and along with that, around that time also, I think before that, or maybe I don't know when exactly, but IKMC trial also was published around the same time. I think this one got published in October, I think, and IKMC got published in April. So actually in 2021, two important trials related to neonatology got published. IKMC, which was a well-conducted study and funded by WHO, with a lot of planning. Actually, we began planning since 2017, I think. Showed that it was much more useful. KMC was much more useful than IKMC than just plain KMC. So that was one example of a trial, which was again a multi-country trial, which showed benefit. Helix trial, on the other hand, again a multi-country trial. But if you look at the publication, and a lot of people have pointed out that probably the way in which the trial was done, selection of centers, etc., was not really great, and hence we got the results that we have got. Not really surprising, and I don't know if many people would be aware. A long time back, I think around 6-7 years back, there was a study published in Lancet, which showed that when antenatal corticosteroids were used in developing countries, they were not supposed to be useful. And if you had just looked at that one trial, you would think that we should not recommend antenatal corticosteroids. So that led to subsequent trials, Action 1, Action 2, and Action 3, which show that the better conducted trials, which show that antenatal corticosteroids are useful. So if you look at just 3 trials which I mentioned, one trial should not lead us to
Yes.
believe that therapeutic hypothermia is not useful, and that is what NNF did. But I just wanted comments on, you actually commented, but if you can elaborate on the comments of NNF as far as giving therapeutic hypothermia according to the guidance statement. What do you feel are the comments?
I felt it was very stringent. Actually, they made it very tight. That actually they have made it only if you look at end. If you have a baby who is 7.0, you need a Apgar below 5. You need a history of acute insult. Then you are going to end up with very severe group only. Okay, we are not going to have a moderate group. We are likely to be, if you look at the studies prior done even in Western world, moderate group was the group where we could avoid the injury. So I don't know whether that can be little bit loosened up, that that criteria can be changed. I can understand why probably would have been done, but still, if you go by that criteria, it is very difficult to get this kind of babies in 6 hours from any other unit. Actually, sometimes you can see that babies don't arrive in 6 hours. These babies are
the ABG and all also is within 1 hour. Within 1 hour, even if the baby is delivered in the same hospital, many people will find it difficult to do ABG within 1 hour. So imagine patients coming from outside, we will almost never. So it looks like a indication which can never be done, kind of ideal indications which can never be done. And
yes,
if you look at the NICHD indications, which the trial which Sita Sankar and all conducted, their indications were quite loose as compared to other studies, and they showed a benefit. So I feel that those criteria are quite restrictive. So do we have any questions? And I have other questions also which we can discuss. But do we have any other questions in the chat box or on YouTube?
Yes, sir. One question is there.
Yeah.
We have one question. It is asking whether cooling of neonates, if they present after 6 hours, say moderate to severe HIE, then if yes, then till what time shall we offer them?
I think whatever I gathered from my experience and whatever I have seen on most of the studies, beyond 6 hours, it is hardly, the insult has already been done. So some of the studies do allow it up to 7-8 hours, I think maximum. But beyond that, I don't think anybody would allow that. I think there has been evidence as well. Beyond 6 hours, the study showed that there is no actually improvement in, I mean, there is no change in the outcome. So that is my take on that.
Yeah, so I think there are 1 or 2 trials which are ongoing or which will take place for beyond 6 hours. But I don't think we can make any evidence-based statement saying that we should or we should not do. So currently, I think you cannot do it in a therapeutic sense. So in terms of as a practice, you probably cannot do it. It is not the therapy of choice as a practice. And Dr. Chilai wanted to make a comment. Madam, can you please go ahead?
Yeah. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. Nice presentation, Jatin.
Thank you.
Just wanted to little bit share our experience. We
Yes.
started therapeutic cooling last year with an automated machine, Criticool, and naturally I don't have the long-term follow-up of 24 months at this, but
Yes.
my initial immediate outcome data of the 30 patients that we have enrolled,
Yeah.
my inborn babies had a better survival than my outborn.
Okay.
So the point that it comes to, because inborn gets resuscitated within 1 hour, I have my cord blood gas or this
Yes.
analysis and the other problems. So definitely immediate survival was better in inborn asphyxiated. So your point of, if we stick totally to our NNF guidelines or the guidelines which have been taken for enrollment, because we stuck to that,
Okay.
I had problems with outborn babies. So
Yes,
I
ma'am.
think because within 6 hours, Apgars are not available in outborn babies. But then we had to look at the pH and base deficit and lactate.
Yeah.
So there were many considerations which we had to look into it. And the survival, overall mortality, and my control group was the standard care group.
Okay.
Because what we had only one machine. So during that 96 hours, any baby who came and was asphyxiated was automatically into the control group.
Control group. Okay.
Because had there been more than one machine, probably I could not have randomized them into a control group. But preliminary data wise, yes.
If I'm not wrong, I think I had a comment that in Helix group also there were more of outborn babies rather than inborn babies. So there has been a debate that could that be the factor which contributed to the outcome of the Helix trial.
Okay. So in the
one more
Helix
thing,
trial,
Somshekhar, for example, getting an Apgar and somebody doing a proper resuscitation, probably in a teaching institute or wherever we have at least residents who are trained in NRP, even the resuscitation is better off than an outborn baby coming from a PHC or a CHC. So that also, even immediate stabilization makes a difference in inborn and outborn.
Yes.
yes, ma'am. So just to share about, I wanted to talk about Eric's trial, but before that, I wanted to ask you, Jitin, you have practiced in the UK, you were part of the trial, and you know how things happened there. And then now, in the last almost 10 years, 12 years, you have been practicing in India. You have cool babies in India, you have cool babies there. So, in your personal experience, what is the difficulty in cooling in India as compared to cooling there? Apart from the normal kind of patients that you get in
Sir,
practice.
as ma'am told, I would share the same things. First of all, very difficult to get the criteria A. If we want to know that really we should be cooling our criteria A, we don't get sometimes within 6 hours. We just get that some resuscitation required, no Apgar scores, there is no pH or anything. We just had to rely on our clinical assessment. And I had the pleasure of having CFM with me. So sometimes I put the electrodes and I see that if there is a moderate encephalopathy, then even we start cooling on that. So there is a always challenge because you don't get the exact history and objective criteria as well. But CFM is quite, I guess, helpful in this matter.
Okay. Regarding to the Helix trial, if you look at the Helix trial and the centers in which the Helix trial was done in India, they're actually all very busy centers. They're good colleges, but you can see that in the report they have mentioned that 2 to 4 neonates in the ICU were managed by one nurse. So would it be the same in UK where you practice for intensive care nurses?
Sorry, did you say it again, sir? In what happened in busy centers?
Helix trial. In the Helix trial, if you look at the Helix trial, there were around 2 to 4 patients per ICU nurse.
No,
okay?
Sir.
So
in UK it is 1:1. The cooled baby will be allocated to only one nurse till the baby is warm, and that baby will be a part of intensive care where there is a norm of BAPM guideline, British perinatal medicine guideline, that any ICU baby, the nursing ratio would be 1:1 only. So there was no doubt about it.
So if this is the kind of center, like now forget about cooling, even other normal intensive care, normal levels of intensive care, just with ventilation and all. If you are managing 2 to 4 babies with one nurse, it is not going to give you good ventilation outcomes also. Forget
Yes.
about cooling outcomes. So I think that is one major issue that is something which they have not noted, and it is completely at variance with the Western data. And so to say that based on that trial that uh, you can say that you should not cool when you don't have good intensive care facilities, or you don't have good enough nursing. So that might be a better statement, sir, other than saying that people in low and middle income countries should not cool, because there are many hospitals in India, private hospitals in India, where you would have one baby cared by one nurse, or at the most two babies cared by one nurse. So that kind of, or three babies being cared by two nurses, something like that. So we in many hospitals in India, you would have such kind of facilities which are there in the UK or US. So I think in
Yeah.
those places should be able to cool. So making a blanket statement, so the Helix trial is kind of represents what happens in the public sector, because these are all public sector hospitals, and does not represent hospitals which may not have the same setting.
Yeah. So, sir, it applies also to same thing. I mean, I'm not sure when surfactant came in, was there a LMIC trial on surfactant, or was it adopted from the standard practice? What we extrapolated that, we adopted their practices, and we have no arguments on that surfactant is helpful. So wondering why this.
So very good question. So we really, it really doesn't matter so much. Another question that I had.
That number of asphyxiated babies going to a private sector, because one of the private unit in Baroda had it, but they could hardly enroll a patient because all those counseling and consent, it comes down to that they ultimately come to a public sector hospital. And I do agree. I think better intensive care facilities and more monitoring and knowledge and the training of the unit is there. They should venture upon doing it, and not that like anybody just puts the baby in therapeutic cooling.
Yes,
because once it becomes an expensive modality, the things going to private sector, number of them immediately comes down.
Yeah. Okay.
Yeah, so I was really interested because there is a centers, we know all the centers, and I really want to know what are their outcomes for preterm babies as compared to preterm babies in the UK. So if you compare preterm babies in the UK outcomes to outcomes of preterm babies in these centers, and if you find that the outcomes are poorer, would you say that people in low and middle income countries should not treat preterm babies? It would be the same argument.
No.
That would be the same
but
argument.
We are doing better off with KMC itself.
Yeah.
I'm trying to put an argument saying that you cannot use that argument, because unless you have similar outcomes, you cannot say that you people should not do it.
Yeah.
Blanket outcome like low and middle income, you can say similar settings
I agree.
should have good settings. Yeah. And Jatin, one more question.
Yes.
You mentioned MRI and lab support. How important it is for centers to ensure that these babies get MRIs done and good lab support? How important it is for it?
Sir, I would say MRI, I still would consider that it should be available, but not within the unit. I think lab support is mandatory. If you don't have a lab, these babies are very sick babies. I mean, it is like, forget about cooling. If you have a ventilated baby and if you don't have a blood gas facility, then there is no point in, you may end up with hypoxia, hypocarbia. So we just need to stick to our basics actually. And basic is that you need basic labs actually, that is for sure. MRI is something which will be prognostication, or if you are in dilemma. So like I work in private unit, it is not possible to get MRI, to be honest, on first week or second week immediately. Sometimes parents also, we had a lot of things, but it is like that. I have a facility of MRI. If I want to get it done, it's not difficult for me. I can arrange a transport. Even a sick baby will go in transport and get an MRI done. But it is very helpful to explain prognostication. We do have a group of parents who are really demanding, who are very knowledgeable. We have a very diverse group. So I said, it should be available, MRI, desirable. Lab, I would say it is mandatory. If you don't have a lab, then I don't think we should be able to cool that baby. That's my take on that.
Thank you. I don't know if there are any other questions, because I have a few more questions. Or rather, a comment. If you look at the trials that are done in Pondicherry and Vellore. I remember they actually had very good outcomes with ice pack. Ice pack, managing babies on ice pack
Yes.
cooling is quite difficult. Phase change material is quite easy relatively, and it's more standardized. But ice pack, but they had good neurological outcomes even in babies who were getting cooled by ice pack. So we tried in 2012 or 2013 to do ice pack cooling, and then we gave up because it was too complicated for us. But anyone has any experience in ice pack cooling? Urvi, you have used ice pack by any chance?
No, sir. We don't use
Okay.
that thing.
Madam, I don't think Madam has used.
No,
Yeah,
we didn't
madam.
use the ice pack. I just started after I got the automatic.
But sir, I had one experience to share. Ice pack, I mean, long back, we had to transfer a baby from long back, which was a very affluent family, was very well educated. They knew about cooling actually, and they wanted to get transferred for that. I would say around a couple of hours of distance from hospital. We had to retrieve that baby in ambulance. So obviously in ambulance, it is difficult. So we use that gel packs actually. Frozen gel packs for transport and to reach in our facility within 6 hours. I thought the temperature control is very, very difficult. It led to temperature of 32 degree when the baby arrived to the unit. Okay. And there was no way I can control that in the transport itself. So if that would have continued, this baby would have ended up with the temperature of below 30 or something like that, which could have been more detrimental rather than doing HI bit. So that was my only experience with the cool packs.
So same reason we use gel packs, and we had the same experience to get very cool too much, and then we had coagulation abnormalities. So then we said forget about it, we will not use it any longer. So we cooled I think 2-3 babies, and then we stopped cooling babies with gel packs. Madam, you're saying something.
Yeah, could I make one just question
Yes,
to Jati?
Yeah, ma'am.
See, everywhere in all trials, syndromic or malformation babies would have been excluded. This is a personal, case study that I know of. That baby was given, it was abroad. Baby was given therapeutic cooling. Later on diagnosed as Down syndrome baby. So if legally we were to, looks like a Down syndrome baby, but has all the criteria fitting into our therapeutic cooling, should we cool or not?
I think so, ma'am. Down syndrome should not be a contraindication. I think when there's a congenital malformation, something lethal, that would still it will be open for debate. I guess your question, but in my view, if only Down syndrome would not disqualify this baby from getting cooled. I don't know what Dr. Somsekar.
It's just for discussion. I was asking.
No, madam. I think congenital anomalies which are life-threatening means if you cool the baby is more likely to die. Like that those kind, then you should probably not. And that is.
But other than that, Down actually should not be, na?
Down should not be.
Ma'am. Downs, even cardiac, even suppose there is VSD or ASD or even CCHG, congenital cyanotic heart disease, which can be managed. Even those babies you can cool. I don't think that should be a problem.
Because recently we had this dilemma. Baby PPHN, but as soon as we did the echo, it turned out to be diaphragmatic TAPVC. So we took a decision because we had to shift the baby to UN Meta urgently, and decided against, gave a standard care and shifted as to the thing. Baby has survived, baby has been operated, but there was this again a dilemma, TAPVC, whether I do therapeutic cooling or I go for the cardiac management.
I had a comment.
What would be debated, Jatin? I mean, this is my recent, just 2 weeks back experience.
No, I guess, ma'am, you're right. See, I think we have to know when we want to cool. There are babies, the neonatal encephalopathy is a broad term. One of the causes is HI, where you get benefited from cooling. But suppose this baby had a metabolic encephalopathy, I don't think that baby would be benefiting from cooling therapy.
Cooling it.
And that was one of the criticism, or I'm not sure what, but I had been through this debate once, that the group of therapeutic hypothermia in Helix, they were not all known to have intrapartum asphyxia actually. The cord pH was not available in OR1, and encephalopathy, was it due to some other cause or not? That was not sure. So what I suppose, if you can establish this is a HIE due to perinatal asphyxia, then I think cooling is a right treatment for that. And ma'am, second you told about PPHN. I think PPHN is a relative contraindication. Sometimes people have stopped cooling, but that is a clinical discretion only. If you feel that your cooling therapy is going to harm by putting the baby more into cardiac dilemma, then I think it is you are right in doing that, to stop cooling therapy in that one, ma'am.
No, here too, because the child had the hypoxia and we had differential saturation. Like by the time you stabilize, ventilate, and I could get the cardiac diagnosis that this is definitely diaphragmatic TAPVC. So took a decision on the side not to cool, but was wondering.
I think that is fair enough, I guess.
So another thing is you can start cooling.
Yeah.
And stop. Hello.
But you can always stop cooling if you think there's some problem that is going to happen. So I think, but if you already lost time to start cooling, then you really can't go back. So that's something which is towards cooling rather than not towards cooling. One last point. Generally, we say that when we use phase change material or gel packs, fat necrosis happens. I was shocked to see in one unit where they were using one of these servo control devices, good device, expensive device, that baby had fat necrosis. And it was a very good unit, so with good amount of nurses, etc. So the point that fat necrosis you will see only in gel pack or PCM and not in servo controlled is something which we should think is not correct, and we really don't know the differences between.
No, I would share my experience. The 28 or 29 in the early series, I didn't have a single subcutaneous fat necrosis in this automated, but the last one, after 48 hours, when I looked at the baby, the back, I felt that redness and the early changes of subcutaneous fat necrosis was coming, and the baby otherwise was stable. I terminated the cooling by 60 hours, to tell you the truth, because till now we were not seeing, and this was the first time I saw that this is coming up with subcutaneous fat necrosis. I omitted at 60 hours, but then I was also wondering, till now I was not getting why did I get it here in this particular.
I can see Ashish Mehta logged in. Ashish Bhai, if you can comment something.
Yeah. We have one question is left.
It was very interesting.
Yeah, okay, we'll take that question first.
Okay, just sorry.
Question.
There is no question.
Urvi.
I mean,
just if people don't have a cooling device, so what other neuroprotective strategies we can advise?
We will not take that question. We will have another lecture for that.
Another session for that. And we may even
have a question from the audience,
which have to be taken care of.
I know. Maybe Jatin bhai, you can elaborate 2-3 points, and then we can
see. There was a Xenon trial which failed, I guess. There is a new erythropoietin has some basis on that. If it is started in therapeutic window, there is some evidence that erythropoietin can be used. Though I have not had personal experience of using erythropoietin for neuroprotection. Even melatonin has been tried as well before. So these are the couple of medications, but Maxelf, yeah, ma'am, Maxelf as well. But I don't think I've used it for my personal any of my babies.
Yeah, but Xenon and one of the anti-conversion, two are looking very promising. Beyond cooling, if you look at the treatment for the hypothermia, beyond the hypothermia, it is Xenon and that tegabatrim, or which one of the anti-conversion, that is looking very promising.
Xenon trial had results have come out, and I don't think it was supporting Xenon therapy, as far as I'm aware.
Xenon with the anti-approved drug, I don't remember the drug name, that Xenon plus both combined, that has shown very good result.
Okay, I'm not aware, sir.
But it is too early to make any comment on that. Yeah. This is just side question that what beyond cooling, that's the thing.
But I think
you would be knowing that Sita Sankaran's trial cooling beyond 6 hours. They had to stop it because the study itself showed no benefits.
Yeah, true. One thing I wanted to ask, we produce many leaflets, sir. ROP leaflet is there. You have a hearing screening leaflet. I think we need to create awareness among parents as well. There is something called this cooling therapy. Now it is very dilemma because all these trials and all, but it is very difficult to explain cooling to a parent who doesn't know why do we need to cool. So you have, like ma'am said, that it is a very short window. The private practitioner will not be easily able to penetrate parents' mind that this is a something therapy which is a newer invention. So this is just my thought on that. Something which should be patient leaflet should be available. I mean, I remember in UK they did used to use that for patients' benefit. That you have,
Jatin,
yeah.
Jatin, I fully agree with you. Recently, because of this overuse of the social media and the easy accessibility to the helix trial results, few
I know.
weeks only, the babies which were pulled in Mumbai, the relatives they took to the went to the neurologist saying that can you open this trial, and
Yeah.
ultimately eventually they are from Gujarat, so I was involved into the whole discussion.
Yeah.
But believe me, the neurologist started in Mumbai, the cooling and all that. After 36 hours, he decided to let them take a decision whether they want to cool or not. And to everyone's surprise, relatives decided not to cool. You know, so ultimately has to give Dama that if baby stays with me, I'm going to cool. If you do not want to cool, take Dama, and they did they took Dama.
Okay.
So that's the reality of this useless trials and all this which are there on social media. So I fully agree with you that someone need to come out with those at least some information, right information for the
Yeah.
colleagues.
So one more point is, I think what we require, I think, is what do you say, one-on-one trial between phase change material and what do you say, servo control device.
Totally.
Generally, we say servo control is better, servo control is better, but we really don't know how better it is. Suppose something is costing 3 lakhs, 4 lakhs, and another thing is costing 20 lakhs, and if the difference of NNT is just one, NNT 6 and NNT 7.
It's not 20 lakhs, it is just 8 lakhs now, bhaiya. It's just 8
That is
lakhs.
because PCM has come in the market. The whole point, what I'm trying to say is, we need to have a head-on-head trial, no? Because everyone may not be able to afford even 8 lakhs. Because if you want to do today, we have SNCUs which are spread across India, which should not do cooling today. But suppose in 5 years' time, 10 years' time, they become good enough to start cooling. It is very difficult for us to kind of ensure that servo control thing might be available everywhere, whatever. So, but I think one-on-one trial between PCM and servo control devices is something which would be really interesting, and that would be something which we should probably do.
But the reality is that servo control, I mean, this ice packs and everything will require a lot of monitoring and lot of staffing there. You know?
No,
That's
not ice
biggest
packs.
problem.
Not ice packs. Ice
This is
packs are
PCM,
You
sir.
know the other cooling device.
PCM.
You know other cooling device, gel packs and whatever you say.
And phase change material is quite easy to use.
Yeah, phase
That's
change material, but
and because it
still
might
to
have
change those things.
use in transport. So if you are transporting a baby from somewhere, you put the baby on phase change material, bring to your hospital, and then change to servo control. So that might be another way of looking at those devices.
Okay.
I think we are at now almost 5 o'clock.
Yes.
We should stop. Otherwise, we
We
can
should
continue.
stop, yes, sir. Okay. I first of
Yogesh
all,
bhai is there. Yogesh bhai, તમે છો અહીંયા?
Is left.
Yeah, I'm here, boss.
Oh, sorry.
Please some comments from your side too.
Discussion meeting ચાલે તો પેરેલલ બીજું ચાલે ને.
Okay, thank you.
Okay.
Bye bye.
I think
I
Somshekhar,
thank
as you
Dr.
are saying,
Jatin, sir.
Sheila ma'am.
Yes,
Sheila
ma'am.
ma'am.
like
Yes, ma'am.
something like we have a registry in our own state and list and have the experience of both the sectors and look at it again, because the points that you carried out, blanket, somebody can't tell that you are all not eligible to carry this particular modality of yes, one can understand one's own limitations of the unit or the type of patients we get and how we can continue further. But definitely agree that it should not be that something that this LMIC should not venture into this therapy when another half is telling that it has been quite proven to be effective.
Yeah, there is no one India. There are many Indias. So that at least some Indias can cool, some Indias may not cool.
So when you are telling that during transport, I would tell you this last 1 month, even without cooling devices, we've been getting patients at 31, 32, and 33 from outside.
That is another end.
That's another end, is what I'm telling you.
Yeah.
Because somehow we had a very busy December, January, like even in inborn, we had a 270 admissions. So from labor room to coming to ICU also, we were realizing at times the temperature was fluctuating.
Madam, हमारे दो studies can you utilize that? We have 2 studies which prevent hypothermia from labor room.
I know,
trauma to NICU.
I mean, sir, but yeah, अलीराजपुर से मेरे पास आएगा वो कैसे आएगा? Tell me that. Dahod, Alirajpur, Limkheda. Nearby, we can definitely, there has been an improvement.
KMC transport we can do, ma'am.
Yeah. I think we just need to take it further more to periphery about it.
Yes, ma'am.
Everybody has accepted that as a one of. Even we have been trying now to do that in Kilkila while sending over.
Thank you all. It was a great discussion. Thank you, Dr. Jatin sir, for an excellent presentation and very lucid lecture. Thank you, Somshekhar sir, for the expert opinions. Sheila madam, Ashish sir, for all the opinions and enlightening us with this controversial but a very interesting and important topic. I request Dr. Dipen to conclude, and then I think we can.
Sagnik will give us the certificates first.
Yes.
Yes, sir. Yes, sir.
We would like to thank Dr. Jatin Mistry for being a presenter in Neonatal Pathshala, and thank you for having a very great lecture. This is a certificate from our President and Secretary of Gujarat. Thank you.
Thank you, sir. Thank you.
Just request Dr. Dipen, if it our president to just give a note.
So this is a certificate to Dr. Somshekhar sir for being an expert in Neonatal Pathshala. And sir, you have nicely made this session very interactive. Thank you for your presence and being an expert in this Pathshala.
Thank you. Welcome.
Thank you all.
Thank you, Urvi, for managing everything and putting everything together. We missed having Dr. Divakar today. It would have been good to have him today.
He was in the meeting. His, I think, Dean meeting was continuously on. I called him, but he was not available. So,
thank you.
Okay.
Thank you, sir. Thank you.
Thank you all.
Thank you. Thank you, everyone. Bye. Bye. Bye, everyone.
Thank you. Bye, sir. Bye. Thank you.
Thank you. Thank you, sir.